growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, I'm Dr. Steve Rasner, and you're tuned into The Lionhearted. I know this is going to be released right around the new year, so I'm really focused into the few hundred of you that seem to follow me week in and week out as to taking this year, right now coming up, and really being detailed as much as I can about what I think you should be doing when, with regards to having an amazing outcome for you for 2020. So let me just say this to you. And please, those of you that follow me, I'm pretty sure you know me by now, so you know anything I say is with the intention of helping you. So when I tell you that I just got off the phone this morning with the bookkeeper accountant that I keep besides my regular accountant, besides the person inside my office that provides me numbers for me to judge my decisions by, how much we collected, how much we produced. So I've told you on many occasions, please write to me at Dr. Rasner, D-R-R-A-S-N-E-R, at AOL.com. If you want the contact of anybody that I bring up, like an outside virtual bookkeeper that I've been using for 7 or 8 months of this year. I never did it in my 39 years until this year. If you're doing a couple $100,000 a year, you probably don't need to do it. But if you're doing 500 or more, I would tell you that it's worth the investment to use the person I'm using or find your own, because there's certainly no agenda here. Anything you ever hear me recommend to you has no dollar significance attached to me that I would benefit from it, or I would lose all credibility, and it's just not what I'm made of or built of. But when I tell you that I got off the phone this morning, so my numbers for 2019, and that's what I mean when I share numbers with you, it's only, to help you know what's reachable. And that's not the content of this podcast. The content of this podcast that's coming up is what you should focus in on as soon as possible, skill set wise, for 2020, right? Something you could add right now to your armamentarium of skills that you offer people. Because I think I can't hit it hard enough for you. Because when I think back of every week that went by this year, of the sometimes amazing weeks, we had weeks that ranged this year from a high of $150,000 in collections for 1 week to a low of a couple times of, I think, 60. But when I look back and know that I personally did about 3.5 minimum, and my other secondary office did about 1.1 or 2. I'm telling you this because there's a week or two left in the year, so I don't know the exact numbers. And how that happened, first of all, you have to know the possibilities. And God, if you're tuning in for the first time, you're going to get a wrong impression of me, perhaps, because I'm not telling you those numbers because, oh my God, I'm all about production. I don't even have one chart anywhere in my office that talks about production, quotas, or anything like that. It's really the net result of a philosophy of practice from a GP that I've been giving you for the last year plus on these podcasts. That's what this is. So me sharing those numbers with you, and they're pretty consistent for the last 14 years. I haven't gone up astronomically in any of the 14 years. In fact, to be literal with you, there was a 3-year slump when we had a recession in 2009, 10, and 11. Other than those 3 years, and I've talked about that on other podcasts, every year has had an increase. But particularly the last few years, because really the last 7 or 8 years in all GP practices has encountered another change that we've all had to deal with. and that is the avalanche of corporate competition in our communities, right? I mean, there's no doubt about in my community that if you went back to 2008 or 9, even 10, there was much more individual practices that patients could go to than there are today. There's more group practices because that has become a thing to stay. And if you want to be independent, which is what this model that you're listening to is about, then you have to have different rules and things. I'm not against corporate dentistry, except that I don't think, to be fair, if I'm going to call it the way it is, and I'm not, to be fair, I don't know the details and philosophy and the actual outcomes of all the corporations that are out there. But in general, I feel pretty confident telling you it hasn't enhanced the clinical care of the patients in the public that go to dentists. I mean, that's just the way it is. It's not. There's no corporation out there I know of that is dedicated to improving the marginal integrity of crowns, to improving the percentage of implant success. I don't know one corporation that's owned that way. They may profess that they are quote unquote quality this or quality that, but it's certainly, I don't think, in the best interest of dentistry. And so that's a big thing that's changed. The second thing that you know about that's changed is the unbelievable toxicity to the GP of taking on insurances. You do realize, those of you younger dentists that are listening, that you could take insurance 25 years ago, and I guess even less than that, 15 years ago, and it wasn't going to have a major impact on how you practice. And now it does, for sure. I mean, it's just, don't get me started. It's just ruthless what they ask my colleagues to, and what they used to ask of me to put up with when it comes to reimbursement for the exact same procedures you always used. You know, if any public people are listening to this, why would you think the quality of care would improve if how we get paid for doing exactly what we used to do has changed to the negative dramatically? And nobody cares about it. We're making a living too, you know. So we're trying to make a living too. So how could the fact that insurance payments to dentists that have dropped precipitously in the last 15 years, right? They haven't cut, to my knowledge, the premiums of the employers out there that are providing insurance for these patients. But yet they've dramatically cut the reimbursement to dentists. We didn't change how we did things. In fact, most of us haven't. How would anybody expect that that has added to the quality outcome of services delivered? And I'm so sick of pretending this didn't happen and being politically correct that I want to freak out. I wish I had a forum to speak upon that I thought would make a difference, because I would do it, but I haven't found that forum yet. So for my guys, for the docs that follow the lion-hearted, now you know why I called it the lion-hearted. You know, what is it we can do to sustain ourselves? Not to pile sums of money in our bank account. No, to be able to survive, not taking every toxic insurance that's available to you, and maintain a practice you can be proud of the quality of care that you deliver, the amount of time that you give each patient, the amount of time that your hygiene department is allotted to each patient. It's an hour for me, by the way, and it's been an hour from the day I practiced to now. That's what they get, an hour. I don't hire a hygiene assistant to turn over their rooms more efficiently so that they can jump to the next patient and see them in 41 minutes because that's what corporate dentistry is calculated is profitable. Don't get me started, man. I haven't even got to my subject matter, but I've gotten to the background of why this is so hard for you and why you need to focus and tune in to the concepts that have worked for me. I just gave him my numbers, and they were up from last year by a couple $100,000. And I assure you, I didn't work more hours this year. I worked less. So how did I do that? Well, one of the ways I've done that, and before you skip this podcast when I tell you what the subject matter is, you need to hear it. If you're not doing it already, you need to hear it, and you need to hear it again. And if you're doing it, that is providing, like, which service, I want to nail this again, which service should you focus in on, and what skill set should you first incorporate? And there's not a doubt in my mind that it's oral sedation. I know there's probably four podcasts already dedicated to the subject, and that's not a coincidence because I feel so strongly. Now, when I say that, hold on for a minute. I used to mean that you automatically, if you're going to do oral sedation to a patient, if that's going to be a service you offer, then I used to automatically assume that you had to do, and I do think you should take this road, but you don't have to, that you should do extractions, not wisdom teeth extractions, all other extractions, as well as site development, which is bone grafting. If you're going to do that, you may as well learn certainly some level of surgical implant dentistry. So when I say some level of that, I want to talk about that later in this podcast. You don't have to say, oh my God, I'm never going to do surgical implant dentistry because I'm never going to do ramus grafts. I'm never going to do sinus lifts. I don't want to do things that are going to put me in stress situations, etc. And you don't have to. You can do basic, high quality, focused on level implant dentistry and really add to your personal satisfaction of the services you provide and add to certainly the productivity of your office. I don't want to get ahead of myself, but those of you that have not done it yet, that are listening to me right now, that may provide their first implant in 2020, it's going to give you a takeaway that you're unfamiliar with. There's nothing you've ever done in dentistry prior to that. Not even the best veneer or restorative rehab case you've done. When you have extracted a tooth, when you've grafted bone, when you've gone back 16 weeks later and placed a root form implant, and then restore that implant, it really is a different spectrum of what you are and what you chose to be. And you'll get it if you haven't done already. And I'm simply saying that you shouldn't be intimidated by that field that you are open to as a dentist, because you think that you have to do all this extraordinary, highly advanced other associated levels of implant surgery, because you don't. You could limit it to the easy stuff or easier things. There's nothing easy, but the more simplified, less complicated, more predictable services associated with implant dentistry. But even if you didn't do that, there are many reasons for you to jump in 2020 to sedation dentistry. Now, let me say this to you. I do get a lot of emails about what courses you should take, what training you should take. So I need to make this clearer than I've ever made it before. And those of you in other countries, the same rules I'm about to say are going to apply. I mean, why not just give them 10 or more milligrams of just Valium? And it's one pill, so you don't need a sedation license. Because I've experimented in the 24 years I've done this with multiple combinations. And I feel pretty confident on this podcast saying to you, I don't believe there's a more effective combination for sedation. Remember, Valium's just an anti-anxiety drug. We're trying to achieve sedation. Moderate sedation, to be honest with you, not even minimal. Because you can achieve minimal sedation probably with one drug, Valium, other benzodiazepines, and nitrous oxide. But in most states and in most countries, as soon as you use more than one combination of a drug, you're not just using nitrous, you're not just using Valium, you're using a drug plus nitrous. And in my case, you're going to use a total of 4 drugs. And those of you that have listened before know that those drugs are 25 milligrams of Benadryl, 50 milligrams of Atarax, and 0.25, in most cases, 0.25 of triazolam, also known as Halcyon. And so why? Why would you use that combination? Is it that much more effective? It is. And I'm telling you, from a clinician who's taught this to many other clinicians, and I didn't invent this. This was given to me by a really tremendous clinician in Alabama named John Hoare. Amazing clinician in his own right. He gave this to me 25 years ago. And it's incredibly, incredibly predictable, as I'm going to tell you in this podcast and perhaps the next one as well. Even though I've talked about it before, remember, I'm tying in my end of the year report with my accounting for how I did in 2019. And I'm trying to tell you why I did what I did and why I'm able to speak to you remarkably without burnout, 39 years into the career. And if I didn't have this sedation cocktail that I keep prescribing and recommending to you, and by the way, if it's the first time you're tuning in, simply write to me. I'll literally email you or have Beth email you. And then follow it up with any details, because I keep adding to the protocol as I go on. Like, how do you use it? What do you use? But going back to what I said a minute ago, the first thing you have to do is get a permit to be allowed to do it. Don't do this without a permit. Don't do anything that you're not supposed to do, because you'll get in trouble. And it's just not worth it. It's already too hard without worrying about the board of dentistry being after you or anything. So don't do things just because you think nobody will ever know. Okay. So if you're in another country, if you're in Canada, I believe it's a Royal Canadian College. If you're in countries that listen to me, from Portugal to Italy to Australia, I don't know what your permits allow you to do. So you have to just go to your state board of licensing and find out what they allow or recommend for moderate sedation. Okay. And again, I know I've beat this to death, but I'm going to keep doing it. I've done this for 24 years. I have an amazing body of evidence. And you've heard me say, in 24 years, I have never had one incident that required me to call 911. Oh my God, they're too sedated. I don't know how to get them out of this. Never. Not even close, to be honest with you. Is it for everyone? No, as you'll hear me say later in this podcast. It is clearly, there's procedures I don't think you should do with, not many by the way, with oral sedation that I believe, I'll get to it now, that require IV sedation. If you subscribe to my philosophy and you have learned the triad, or you're in the zone of learning how to treat oral sedation patients, how to do surgical extractions, bone grafting, and you get to a point that you are learned how to do sinus lifts or ramus grafting, or a patient that's real difficult come in and they're uptight and they tell you nobody's been ever able to numb me right, or they're that kind. If there's even a vibe like that, I would tell you that maybe you're best with IV sedation. I'm going to tell you why. I've actually altered my philosophy on this, meaning I'm much more alert in the new patient interview as to whether I think they're a good candidate. And I must say to you, I still think my percentages are 95% of the patients that I screen are good candidates for the oral sedation that I advocate. But that's still 5% that aren't. And the 5 that aren't, it's managing them. Because here's the biggest thing. As soon as that patient becomes a difficult management patient in a certain situation, like you're in the middle of taking their teeth out, and they keep waking up and they'll say, I thought you said I'd be asleep. You need to put me asleep. It directly, immediately impacts the whole case. And you can't have that. And so I'm telling you that if you have a really type A who's over the top in that interview, I would tell you it's not worth it because it impacts your skill set. I don't care if you're the greatest surgeon in your community. When you're in the middle of that kind of stuff, you're doing a filling on a patient, you're doing a crown on a patient, you could always finish that. But you're in the middle of surgery and there's a lot more to go. The pressure, the outcomes, the impact on you personally, it's just not worth it. So I'm more alert to that than I've ever been. And here's the key. When you have patients that are saying, I thought I'd be asleep, it doesn't automatically mean you're not going to be able to do the case. But that kind of patient, that tortures you, they're not ready to be numbed even an hour and a half after they took the cocktail. You got to stop every 60 seconds for something. That's the wrong patient. Because when this sedation recommendation works, which is 95% of the time, it's a friggin' dream, man. It's too good to be true. I said 95, so I don't want to negatize you, those of you that are listening right now. It is so worth the 5% that aren't good candidates, that if you find that out, that's what it is. Over the body of your work of 100 patients, there's going to be 5 that they weren't great sedation candidates because you can't get them out enough for what you're trying to do. But the other 95% make up for that tenfold. It's just unbelievably a stressless environment for you to operate in, and it's an unbelievable mechanism for you to market. It's going to explode your practice. And there's not many things in 2020 I can tell you that will explode your practice. What does explode your practice mean to me? It means that within 6 months there's an impact. That you have patients coming in to see you because you provide this service. So I can tell by doing this today that it's going to take 2 videos to cover this. So I'm going to take 2 because it's too critical for you to give up. Listen, I'm in front of 15 to 20 venues a year outside my office, lecturing like I'm speaking to you right now. And I'll advocate as one of the steps to have a practice that I've been privileged to own for 39 years. One of the steps I'll advocate to get to that kind of practice is a sedation practice. And that means that the patients in our community that come to me know that we offer sedation, that I encourage them to be sedated, that it's been safe for me for 24 years, meaning it's predictable. They give them the medication. 90 minutes after they take it, I walk into an operatory that the patient's lightly snoring. It's dark. I will say to them, hey, it's Doc. I'll rub them on the shoulder. I say, I just don't want to scare you, which is important. If they're sleeping, you have to let them know you're there because you might startle them, 5 minutes into it with a drill in their mouth. You don't want them realizing that they're in a dental office. It's a light enough sedation that you can easily awaken them with touching them on their shoulder. Most of them say, oh, nod their head and smile, and you're off to the races. Do you have to stop sometimes? Of course. In my history, I found it most efficient to have a third assistant. So my chairside assistant is 100% dedicated to suctioning and vacuuming the mouth so they don't have a laryngospasm while I'm working, which is them coughing, which is no big deal if that happens. You're going to find a nice pace with each different patient where how you should work. Do you have to give them a break every 3 minutes for a second? Whatever that pace is, but you will get an amazing amount of work done. What I want to do in the next podcast with you is compare in detail. Why would that be better than you focusing on aesthetics in 2020 or implant dentistry or endo? And I clearly want to make to you now that I'm not telling you not to learn those skills. I'm telling you your primary move is doing what you have to do to get a sedation permit. And in most states, It is 60 hours of didactic instruction for the first year, and then every 2 to 4 years, depending on your state, it's 20 additional hours. And the letter emails I often get are, well, what courses should I take? It depends on what your state, I don't care if your state said whatever they said. You have to take and abide by the credit hours that they demand. Some of them will give you a range of courses you can take that are under an umbrella of what they accept. In some states, they'll accept the DOC course, the DOCS, sedation regimen course that most of you know in the United States. That isn't my recommendation, by the way. I mean, I'm not against the DOCS. I'm simply saying they don't include Benadryl and Atarax, and they give, from my understanding, they give more triazolam than I do initially. So we'll get into specifics in the next podcast, but make it a goal, please, in 2020, that you're not just going to think about it. Go put on your courses to take, get the permit. In the worst case scenario, you don't end up using it. I can't imagine why you wouldn't do that. If you kept it just to Crown and Bridge difficult patients, it's going to increase your practice. There is nothing else anybody can get and win in a debate with me to tell me that would increase your practice more. Not sleep apnea treatment, not anything. So that's it. The next podcast is positively going to follow this with the exact same subject material, except in greater detail. I like to keep these to under 30 minutes for you. Thanks for listening. I appreciate the several hundred of you that tune in each week. It means a lot to me. If you want to know where I'm speaking next year, or you want to come take one of my courses in surgery, that would be the Rasner Institute, RASNER Institute.com. And Beth and I enjoy relating to you guys, giving you what you want in terms of material that I've accumulated over the years to give you the most successful practice possible. Stay tuned. See you next week on The Lionhearted.